Starting the
Okay, good evening, all the participants, everybody, and in continuation with last Eco mini series, Dr. Abhinandan will be taking this journey forward today for aortic and tricuspid valve. What to look for? So, in detail about basics and pathological conditions of aortic and tricuspid valve. So, over to you, Dr. Abhinandan.
Thank you, sir. Hello, everyone. Today, welcome to day two. So, at first, I will start with the aortic. So, what is the brief anatomy of the aortic valve? So, as far as you know, that in case of your mitral valve and also in your tricuspid valve, we call those the leaflets. But in case of your aortic valve and pulmonary valve, we call them as cusp. So there is a basic difference between leaflet and cusp. So this is the cusp that you can see. Let me put on the pointer. It will be easier for to understand. So these cusp actually form a crown-like attachment in the aortic root. So this is the U-shaped attachment. Uh, so and this is the free edge of your aortic valve leaflet or cusp. It's better to say. So what is the aortic root? It starts from your uh, ventriculo-aortic junction and it ends at your sinotubular junction, and it encompasses your aortic valve leaflet and also your sinus of Valsalva and interleaflet triangle that you can see. But interleaflet triangle, always remember, it is the triangular tissue that is towards your ventricular side of your aortic valve. It is actually a part of your LVOT. So this crown-like attachment forms a three-cusp arrangement of your aortic valve. So this is a cut open. You can see there is a thickening over the free edge. It is called nodule of Arantius. And this is your sinotubular junction. This is your sinus of Valsalva, where from your coronaries arteries are originated. And this is your ventricular aortic junction. So first, a basic concept of what is ventricular aortic junction and what is actually basal ring, virtual basal ring. So there, echocardiographically, there is no difference, but anatomically, there is a basic difference. So virtual basal ring is actually found by it is a imaginary line joining the lower end of all three cusps. So if I join by a this is a violet blue color line you can see over here. So this is your virtual basal ring. An anatomical ventricular arterial junction is where from your ventricular myocardium ends and your aortic endothelium starts. So that is what your anatomical ventricular arterial junction. So there is a gap of 1 to 2 millimeter in case of your anatomically, but otherwise echocardiographically there is not much a difference. So this is a better to know. And another thing, this is your aortic valve long axis view. What are the structures that we can see over there? It is your anterior mitral leaflet that you have already aware of. This is your intervalvular fibrosa that is, and this where your aortic valve starts. And always remember in your mid-esophageal long axis view, here comes your RVOT. Here stays your RVOT. So whichever leaflet is near to the RVOT, it will always be RCC. And the opposite leaflet will be either NCC or LCC. And this is your sinotubular junction, and this is a sinus of Valsalva. And here lies between your RVOT and your LVOT, there is a membranous ventricular septum, where from you in a pediatrics, if you hear about your membranous VSD, this is the location where we look for. And then uh, this is your uh, aortic valve short axis view. This is your left atrium, this is your right atrium, right ventricle, RVOT, and pulmonary artery. So the entire this it is It is bounded by intervalvular fibrosa. That is your that whatever you have seen over here in between your mitral valve leaflet and your aortic valve. This is your membranous septum, and here lies your muscular septum. So all your membranous septum VSD that we can see over in these areas, and in the muscular VSD we can see over these areas. So what are the views of the aortic valve? Though the four views of basic views of aortic valve we have already discussed. So mid-esophageal aortic valve short axis view. There is this mid-esophageal aortic valve long axis view, and this is your transgastric long axis view, and this is finally your deep transgastric five chamber view. So these two views are actually for your Doppler interrogation of your aortic valve, and these two are your morphological and your anatomical yeah, description for your aortic valve. So this is a 3D TE view of your aortic valve. This is a en-face view, that is you can see this is from your aortic side. You are looking down whenever the valve is opening. You are looking down inside your LV cavity. So these are the leaflets that you can see. But you can see there are these are looking like there are perforation in your aortic valve leaflet, but that is not a true perforation. But always remember the 3D. It is a aortic valve leaflets. Anatomically, it is a very thin structure. If the as it is a very thin structure, it forms a artifact like this in your 3D TE. So many a times it looks like there is a perforation, but actually there is not. So what are the things that we have to see in the morphology? What are the number of leaflets? The most common thing that will see that aortic valve, uh, uh, except your three valve configuration, there is a bicuspid valve. So this is your bicuspid valve that you can see over here, and this is your quadricuspid, and this is your unicuspid. So not only this cusp, we have to examine whether the patient valve has raphe or not. Well, always remember there is a basic difference between your raphe and your commissure. So this is your true commissure. True commissure always it reaches up to the edge and also reaches up to the margin of your aortic valve. But raphe is not. Raphe, it is actually nothing but your fused elevation of your both leaflets. So many a times what we see actually are bicuspid valve, it is actually one of the leaflets is actually larger, and that leaflet is actually fusion of two leaflets morphologically. So that fusion forms a ridge on the aortic valve, which does not corroborate to a proper commissure or any blood flow through it. So that is a raphe. Number two, we have to see whether the aortic valve is thickened. You can see over here that this aortic valve is a normal. This is your namaste sign that you can see. This is a aortic valve long axis view. So this is nice thinned aortic valve leaflet that you can see over here. Whereas in this pathology, you can see this is a rheumatic pathology. You can see over here there are spontaneous echocontrast in your left atrial cavity. So probably the patient is also having mitral stenosis, and along with that, the patient is also having rheumatic aortic stenosis. So that is why there is a thickening of your aortic valve leaflet. There are few focus of calcification that you can see over here in your NCC or RCC leaflet, but your NCC or LCC leaflet, but your uh, RCC cusp is beyond is without calcification. Number three, we'll have to see what is the mobility. So this in this rheumatic pathology, you can see over here the valve is actually moving less than what is normal. So that means it is had become heavy, and you can also see there is a doming of your body of the cusp. Whereas in this view, you can see there are a formation of prolapse. It is prolapsing into the LVOT. So RCC is actually prolapsing into the LVOT, but it is not yet flail. It is still prolapse, because this is your, if it is a line of annulus, so it is prolapsing beyond the annulus into the LVOT. The concept you remember always, it is like your mitral I have explained. The concept of prolapse, billowing and flail all are same in for the every leaflets. And final thing, we'll have to see what is the calcification. Now you can see nicely what is the calcification looks like. It actually, this is your normal myocardium, other myocardium. You can see over here, it is a far more whitish in color. You can see over here. So this is your calcification. So it is a bicuspid aortic valve, which is a calcified margins. So no aortic root measurements. This is a very common thing that everybody will do mistakes. But what are the aortic root measurements and what are the correct methods and where from we should take it? So from always remember in your left side of your image, that means into the LV cavity, whatever measurement you will take that from your aortic annulus and your LVOT, it has to be in mid systole. So it has to be in mid systole and it has to be from inner edge to inner edge. That means it has to be started from here up to here. And all other measurements of aortic root, that means your sinus of Valsalva, sinotubular junction, and ascending aorta. These three measurements we'll have to take during end diastole. And that will be a leading edge to leading edge. So what is leading edge to leading edge and what is inner edge to inner edge? I'm coming to the next slide. But always remember, whenever you will measure the ascending aorta, make sure you are measuring it at the level of your pulmonary artery. So this is your cross section of right pulmonary artery. So this is your cross section where from you will take the diameter of your ascending aorta. So this is called inner edge to the inner edge. And this is the concept of leading edge to the leading edge. That means if this is your TE probe, if the waveform is coming from this direction, so whichever is structure it is hitting first, that is the leading edge. Then this is the structure of this wall. This is the wall that is actually hitting first by the echo wave. So that is why it is called leading edge to leading edge, and this is called inner edge to inner edge. So the aortic valve area. So aortic valve area, there are three possible formula that we actually follow. Number one is a planimetry, number two is continuity equation, and number three is Gordon equation. Gordon equation I have mentioned separately because it is actually a catheter-based parameter, whereas where cardiac output is divided by 44 into 3, systolic ejection period into the heart rate and root to the power mean gradient. That is your catheter-derived mean gradient. So, as we are discussing on echocardiography, I'll focus on planimetry and continuous equation. So, this aortic valve planimetry, it is mostly done here in your mid-esophageal aortic short axis view. So, mid-esophageal aortic valve short axis view, many a times our aortic valve remains calcified. So, the calcification is not uh, a homogeneous thing. So, one leaflet may be more calcified, one leaflet may be less calcified. So, always remember NCC is the leaflet which becomes more calcified more commonly. So, that is why your may not be, whenever you are measuring in your 2D image, you may not be cutting the aortic valve at your proper opening. So you can take help of your 3D MPR, so that you are cutting exactly at the opening of your aortic valve. So and then you can measure your aortic valve opening. So what are the continuity equation? Continuity equation means whatever goes in, it has to go out. That means whatever blood is going towards the LVOT will come out through the aorta if there is no regurgitation. So suppose if LVOT LVOT has area 1 A1 and LVOT VTI has area V1, then A1 into V1 is equal to A2 into V2. So A2 is your aortic valve area that we are solving. So this is your VTI of your LVOT and this is your VTI of your aortic valve. So VTI, what is VTI? I will come into my next upcoming slides. I will explain it even more. So how do you calculate the VTI, LVOT VTI? So LVOT VTI is the best place to look for in a transgastric long axis view or your deep transgastric view. Deep transgastric view, you put the pulse wave Doppler. Remember pulse wave Doppler in your LVOT, where exactly where you are measuring, you have measured your LVOT diameter. So in LVOT VTI, you will get a waveform like this. So you will trace the entire waveform and you will get the VTI. So this is a LVOT VTI. It is also important very much because LVOT VTI, whenever you are taking off of any patient, even if the patient is having not having any aortic pathology, if you see the patient is having LVOT VTI less than 15 centimeter, that means that you are dealing with a patient with low cardiac output. And this is your aortic valve VTI. Aortic valve VTI, if the valve is normal, there is no stenosis or regurgitation, you can put your pulse wave Doppler. Otherwise, it is better to put continuous wave Doppler. So continuous, you have to put the continuous wave Doppler at your aortic valve opening, and you can see over your this nice waveform. And this waveform you have to just trace it like your LVOT VTI, and you will get your aortic valve VTI. And this is your aortic valve mediasophageal aortic valve long axis view, where you will get the LVOT diameter, where from you will there is 2 pi r square, you will get the LVOT area. Remember, always remember, while putting it into the formula, you are measuring the diameter, but what you are putting into the formula, it is your radius. So always divide the diameter by 2. And while measuring LVOT and aortic annulus, it is always you have to remember that LVOT and aortic annulus both are actually not circular. It is elliptical. Whatever the measurement that you take in your 2D examination, that measurement is actually, it is a shorter axis of your ellipse. So whenever you'll take a proper that's MPR method, 3D MPR through your LVOT or aortic annulus, it will actually give you both the axis of your LVOT. So you can see over here in this example, there is one axis is 2.46 that you actually measure, but another axis is 2.71. So there is a gross difference of your 0.25 centimeter. So and by this cross section also you can measure the area directly. So what are the aortic stenosis severe criteria? If the aortic valve area is less than 1, the aortic valve mean pressure gradient is more than equal to 40 millimeter of mercury, and your peak velocity is more than equal to 4 meter per second. Always remember, don't forget that the whenever you will tell in your exam, don't forget to mention mean pressure gradient and peak velocity. So this is your V max, this is your mean pressure gradient. Many a times students get confused with that. What is the low flow, low gradient severe AS with reduced EF? This is a broad, this slide you can just take a snap. This is a thing that you have to remember always. What are the actual difference? The patient is actually having a severe AS, but still aortic valve area is less than 1, but your peak velocity is less than 4, your mean gradient is less than 40, and your EF is less than 50, and your stroke volume index is less than 35. That means your LV is actually hypokinetic. It is not contracting properly. So that is why it is producing less cardiac output, resulting into uh, smaller stroke volume, and EF is also less. So that is why it actually produces less gradient. So always remember, the velocity and pressure gradient is actually flow dependent parameter. So these are actually depends on your flow. Whereas in paradoxical low flow, low gradient severe AS with preserved EF, where EF is becoming more than 50%, but stroke volume is less than 35. When it occurs, if the patient is having severe concentric hypertrophy and its lumen of your LV lumen is very low. So if LV lumen is small, so that also produces lower stroke volume index. So it is a paradoxical low flow, low gradient in spite of having. Why it is paradoxical? The patient is having good ejection fraction, but still it is a low flow, low gradient. So aortic valve VTI, it is only done in deep transgastric 5-chamber view or transgastric long axis view. So continuous wave Doppler we have to place at the aortic valve opening, and it will give you in a in a case of AS, it is give you the waveform like this, and you can see there is a much whiter waveform. It is a smaller waveform. It is a waveform of your LVOT. By this, in this image, you can actually measure your DVI. I am coming to the next slide. So what is DVI? It is a Doppler velocity index or dimensionless index. It is actually VTI by of LVOT divided by VTI by of aortic valve. So whenever there is a discrepancy of whether the patient is having severe AS or not, we can take help of a DVI. It is actually more appropriate for your prosthetic valve, but it is still, if it is a its value is less than 0.25, we can still consider native valve as a stenotic, severely stenotic. So in case of aortic regurgitation, we have to what are the things we have to keep in mind, that what are the things we have to we have to find in your echocardiography examination. Number one, why it is occurring, what is the mechanism of AR, what is the etiology of AR, why it is occurring, how it is occurring, how severe is the AR, what is the location, that means which leaflet is the pathological problem, if there is any associated AS, how is the aorta and what is the LV. So whenever you are dealing with any regurgitation or stenosis of any valve, always think of the chamber before and the chamber after. So what are the echocardiographic criteria to grade aortic regurgitation? There is your PHT, vena contracta, Z by LVOT, regurgitant volume, regurgitant fraction, EROA, and aortic backflow. So in case of severe, the PHT becomes less than 200. If it is a vena contracta, more than 6. If Z by LVOT more than 65%, regurgitant volume more than 60, regurgitant fraction more than 50, EROA is more than equal to 0.3, and there is a hollow diastolic flow reversal in your aorta, descending thoracic aorta. So these are the severe criteria. But always remember, whatever I have mentioned over here, it is for your chronic aortic regurgitation. It is, all of them are not true for your aortic acute AR. That is in case of your endocarditis or sudden rupture of your valve cusp or something like that. So vena contracta, it is just similar to like any other valve we have already discussed. That this will give you the narrowest portion of your colored Doppler flow. It will give you the vena contracta. So vena contracta, we can measure either vena contracta area by 3D, or we can measure the vena contracta width. So in this example, like this, it is the narrowest portion you can see over here, and you have frozen the image and you have measured it 0.429. So this is a moderate MR, sorry, moderate AR. So pressure half time, the things I was discussing just before that, that what pressure half time, what is pressure half time? Pressure half times means that uh, whenever the blood is during aortic regurgitation, whenever the blood is flowing from your during diastole, flowing back from your aorta to your LV. So the force by which the blood is flowing from aorta to the LV during diastole depends on the pressure gradient between your aorta and the LV during diastole, right? So the pressure gradient, whenever there is an increased flow, that means the pressure gradient will become equalized even faster. So that means that will give you a shorter PHT. So more the severe is the aortic regurgitation, shorter will be the PHT. So more faster the pressure will be equal to the half of uh, uh, the equalization of the pressure will be much faster. So in case of your mild aortic regurgitation, whereas the PHT will be longer, it will be more. So that is why it is always remember more severe, lesser PHT. So this is how actually you can measure the pressure half time. You will have to trace like this from your topmost point up to the lowest point from where the abrupt downfall starts. So this slope will give you the pressure half time, that is 190 millisecond. That is giving you a severe AR. Now, jet width by LVOT width. Now, always remember, this is the examination. It is only true if the AR jet is central. If the AR jet is eccentric or it is a wall hugging, just like your MR, you cannot determine the severity of AR by jet width by LVOT width. It is only true if it is a central jet. So, you can measure either by freezing the freezing the image and measure by entire LVOT, width of the LVOT and the width of the jet, or you can put a M mode, color M mode, so that will give you the picture like this. So this is your forward flow and this is your regurgitation. This aliasing you can see over here, it is your regurgitation. So this is your entire LV and this is your regurgitation. So this will enter LVOT and this is your regurgitation. So this LVOT, uh, the how much percentage is your this width is out of this width of your LVOT? That is the question that you have to solve. So regurgitant volume, how you can calculate? So remember the regurgitation, uh, when it is occurring, aortic regurgitation, it is occurring during diastole. So during diastole, a significant amount of blood is returning back into the LV, okay, during AR. And also during diastole, a amount of blood that is going from LA to the LV. But in the next cycle, the blood which LV is pushing into the aorta, a percentage of blood is further returning back into the LV. So that is the whole scenario occurs in during aortic regurgitation. So whatever the blood is going into the aorta, that is stroke volume into the aorta, that is equal to whatever blood is returning and whatever blood is coming from your LA, right? So the entire volume of regurgitation is equal to stroke volume of aorta minus stroke volume of mitral. Stroke volume of aorta means whatever blood is going through the aortic valve during systole. So what is that? There is area of LVOT and VTI of LVOT. If we multiply, we'll get the stroke volume of aorta. And in stroke volume of mitral, you have to calculate the area mitral into the VTI mitral. So this will give you the SV stroke volume mitral. If we subtract SV mitral from your SV aorta, you will get the regurgitation volume. So regurgitation fractions, it is the fraction of your stroke volume of what is the volume of regurgitation. Now, how the EROA is calculated? If there are two things possibility. If there is no PISA formation and if there is a PISA formation. So if there is no PISA formation, because always remember PISA formation requires certain things. If the orifice is round, orifice is regular, then only there is a formation of PISA. But many a times you will see a broad jet, but you will not find any PISA. So if there is if the orifice is very much small and orifice is small enough and there is too much turbulence, there is a formation of PISA. So if there is no PISA formation, so volume of regurgitation, that is regurgitation volume, is equal to EROA into VTI of AR jet. So whenever you put continuous wave Doppler of your regurgitant aortic valve in your deep transgastric 5-chamber view, you will get a waveform like this. So you will get a waveform of AR and you have get a waveform of aortic valve, forward waveform. So this is a VTI of AR. So if you trace it, you will get the VTI of AR jet. If you multiply into EROA, it will give you the volume of regurgitation. So already volume of regurgitation, regurgitation volume already you have already know how to calculate. So EROA you can calculate from this formula. And if there is a PISA formation, suppose there is a PISA formation, the PISA will be formed towards your aorta side. So PISA if what is the radius of the PISA? We enlarge the image and we put it in this formula. PISA, the PISA area will be 2 pi into r PISA square, and EROA will be PISA into volume of aliasing, sorry, velocity of aliasing velocity divided by Vmax of AR. So this is your AR Vmax. This is the same formula by similar formula as we see in a we have seen in a MR. So what is diastolic flow reversal? So uh, this is the thing. Whenever there is a whatever happens, whenever aortic valve closes during diastole, uh, the aortic valve closes, there is no forward flow into the aorta. So the elastic recoil of your aorta pushes the blood backside into the towards the aortic valve, and if the aortic valve is closed and it is not regurgitated, so that blood will stop over there and it will flow into the coronaries. So that is how the normal patients, normal persons have. So this is your systolic. If we put a Doppler over your descending thoracic aorta long axis view, you will get a waveform like this. So it is a normal patient. So there is a systolic flow and there is a small initial diastolic reversal. So this is a normal thing. But in case of significant and severe AR, there is continuously blood will be continuously leaking back into the LV. So that means the blood will be continuously flowing and it will create a waveform like this. So the end diastolic velocity will be more than 20. So if the end diastolic velocity is more than 20 and it is flowing throughout the diastole, that means it will tell you the exactly the patient is having severe AR. So this is your systole, this is your diastole. So you can see over there at the end of the diastole also there is a flow. So yeah, if we measure it, if it is more than 20 centimeter per second, that means you are dealing with a severe AR. Now we have to see few images or few loops we'll have to see. Now, can you appreciate there are three leaflets that we can see over here. Now you can see there is a coaptation gap over here forming, and in the if you put color Doppler in your mediasesophageal aortic valve short axis view, you can see there is a flow acceleration over here. So in this image, you have already seen this, and you have put the color Doppler. Now we can see the color Doppler. It is not a central. It is almost a just like your wall hugging that we have decided already discussed in your mitral class. So this is your eccentric jet. It is flowing across the NCC or LCC. This is another example. Now you can see the jet is at the center, and you can also see there is a small gap is being formed in between the central opening. So in the previous example, can you measure jet height by LVOT height? No, you cannot measure. And also there is a poor, you can see over here, there is no formation of PISA also. Proper formation of PISA is not formed over here. Same patient. Can see the valve is thickened, tip is thickened. It is a rheumatic pathology. And also you can see a central jet. Now in this central jet, you can put M mode over here over color Doppler, and it will give you a jet height by LVOT height. Here you can see the clear coaptation gap between your aortic valve leaflet. It is thickened. There is a severe AR. And there is a formation of PISA as well in your mitral valve that you can see over here. So there is a doming of your mitral valve leaflet as well. So you are dealing with a rheumatic aortic regurgitation along with rheumatic mitral stenosis. Now, can you see anything over here? Let us see in our other images. You can put color Doppler, but you can see the direction at which the jet is going. It is not towards the center. Now you can see this is a case of a vegetation, infective endocarditis of your aortic valve, and you can see there is a eccentric jet of your aortic valve. Same patient, deep transgastric 5-chamber view. You have put the continuous wave Doppler over here because it is aligned over here, and you can get the continuous wave Doppler. Here you can see over here the root is dilated and there is a central coaptation defect. Now you can see there is a central defect and there is a root dilatation. It is a ascending root, sorry, aortic root aneurysm. And you can see over here there are flow acceleration during systolic flow as well. It is due to increased flow. Now we'll discuss about tricuspid valve. So tricuspid valve, it is the largest valve of your heart. Uh, so it is actually one of the most difficult valve to image. So always remember there are two axes of that is the anterior and towards the posterior that will cut through your anterior and posterior valve, posterior leaflet, and there will be a septolateral axis that will be your minor axis. So in case of your, it is a major and minor axis, but it is not a high and a low point. High and the low point will be your, this will be your anteroseptal and your posteroseptal. This will be your highest point, and this, the lowest point will be this yellow line. That is your anterior towards the posterior or septal. So what are the views that we examine in case of your tricuspid valve? So the first view will be your mid-esophageal RV 4-chamber view. Don't get intimidated. It is just a mid-esophageal 4-chamber view, and you have to just rotate towards the right, and you are focusing only on your tricuspid valve. So this is your mid-esophageal 4-chamber view. So this is a mid-esophageal 4-chamber view focusing on RV. You can this is your this is the view where you actually measure your tricuspid valve annulus. But always remember, you have, while measuring the annulus, you have to measure both the axes. So this is your minor tricuspid valve annulus. Here, what are the leaflets that we can see? It is a septal leaflet, and this is your anterior leaflet. Whereas in a mid-esophageal right ventricular 2-chamber view, it is 90°. It is a modified view for the tricuspid valve. From this image, if we rotate the omniplane angle towards 90°, you will get this image where the valve will cut, the image will cut through anterior and posterior. So this is your 4-chamber view, and it is just an orthogonal image of your 2-chamber view. Next, this is your mid-esophageal RV inflow-outflow view. This is one of the most important view that you will have to practice. There is mid-esophageal RV inflow-outflow view. It comes between 60 to 80°. It is if you forward rotate from your mid-esophageal aortic valve short axis view. Why this is important? Because right now the more the tricuspid transcatheter procedures are done through this view. So this will give you the high point of the tricuspid valve, and also this actually give you the RV OT, and you also can see the pulmonary valve leaflets over here. Here you can see this will be your anterior leaflet, this will be your posterior leaflet, and this is your mid-esophageal modified bicable. that you already you have practicing, that if you forward rotate another 30 degree from your mid-esophageal bicable view, so that will give you a modified bicable tricuspid valve view. Because why this valve is important, view is important, because this is the view where you can put Doppler over the tricuspid valve if there is any TR or TS. So what are the other views that we can discuss? That is lower esophageal coronary sinus view, or in other words, it is just a deep esophageal tricuspid valve view. That is the 29th view of your AAC recommendation, where you can see your septal leaflet and your uh, posterior leaflet. But here, why it is important? Because in this view, if we go little down from your mid-esophageal four-chamber view, uh, we can see the morphology of your tricuspid valve much better, because there is no left-sided structure obstructing your view. Because many a times it is very much difficult to image, because of there is a if there is any prosthetic valve over mitral area. So here you will there will not be any mitral valve will be seen in this image, and you can see perfectly your tricuspid valve. And also if keeping this image, if you change the omnipole angle to 120 degree, it will give you a RA appendage. You can put a Doppler also, you can also see if there is any thrombus formation over there. And also it will give you a anterior and septal leaflet. This is a transgastric basal short axis view. It is a gastric views. It is from the transgastric basal view. If we rotate towards the right, it will give you the basal view of your three scallops of your uh, leaflets. Three leaflets, tricuspidal leaflet. That is septal, there is a posterior, and there is your anterior. And this is a RV inflow view. It is actually the angle is around 90 to 120 degree from transgastric long axis view. If you rotate the probe towards your right, you will get this transgastric RV inflow view. It will give you the tricuspid valve subvalvular apparatus, just like your mitral valve. Deep transgastric RV inflow outflow view. It is a nice view where you can see over here spectral Doppler of tricuspid valve and spectral Doppler of pulmonary valve. You can examine over here. It is just like your opposite image of your mid-esophageal RV inflow outflow view. But same image, if you can rotate to 130 degree, it will give you the exactly opposite image. So why it is difficult to image? It is a far field structure. They have thinner leaflets. There are variable number of leaflets, and the RV anatomy is complex. So always remember, if you are actually planning for any tricuspid valve examination, particularly, always keep a wedge under right shoulder. That will give you a better image of your tricuspid valve, because it will make the heart more aligned with your TE probe. So the classical image that we actually see of tricuspid valve three leaflets, that is your anterior, septal, and posterior, it is only possible in the only in present in 54%. So rest of the 46% of patients have other configuration. So next most common is type 3B, where there are two P1 and P2 leaflets of your tricuspid valve. There are all possible formulation, all possible scallop rotation. You can see there are multiple A1, A2, there are multiple S1, S2. These are the all possible configuration of your tricuspid valve leaflet. But the thing we actually see, it is only 54%. So this is the image that we are actually uh, I was talking. That is the mid-esophageal RV inflow outflow view, where you can uh, put your X-plane, and you can examine all the leaflets, and you wrote and if you sweep the X-plane through the entire leaflet or entire tricuspid valve, you can actually examine the entire leaflet in your orthogonal image, entire valve in the orthogonal image. So, in this previous image, you can see it is cutting over your anterior leaflet, and you can see over here, this is septal, this is anterior. Wherever in this image, whenever you are going towards your posterior leaflet, it will give you a septal and posterior leaflet. You can also put a color Doppler and put a X-plane through that, and you can actually see and examine the exactly how big is your tricuspid regurgitation jet is. So this is your basal short axis view, where actually you can see all the three leaflets at a glance, and you can see examine your what is the coaptation gap of any TR if it's there. You can put the color Doppler also. You can measure the vena contracta area in this examination. So what are the tricuspid lesions? So always remember, tricuspid stenosis is rare. If it is, it is mostly rheumatic. Regurgitation is far more common, and out of total TR prevalence, secondary TR is 80 to 90%, and primary TR is 8 to 10%. So what is secondary TR? Secondary TR means there is no pathology in the tricuspid valve leaflet itself. It is a problem of something else. So that is a secondary TR. And primary TR, there is a problem of tricuspid valve leaflet itself. So secondary TR is of three types. Either it's due to atrial pathology, due to ventricular pathology, that means RV, or any CIED related. What is CIED? CIED means any pacemaker leads, any ICD leads. These are the leads. If they are causing any TR, that is also called CIED related secondary TR. So this is the 2017 AAC guideline. They have defined the tricuspid valve annular dilatation as an end diastolic diameter more than 40 or more than equal to 21 millimeter per meter square in the apical four chamber TTE view. But this is also true for your TTE examination, TE examination. So this is how you will measure the tricuspid valve annulus at your end diastole. So this is an example of your secondary TR. You can see over that there is a TR jet. This is your midesophageal RV inflow outflow view. You can put directly, you can put Doppler over here, the jet of the jet direction. But always remember, like commissural view, this view is not good for your vena contracta examination. So actually, this view actually it forms a, it cuts through multiple coaptation plane. So it will actually overestimate of your TR. So do not examine your vena contracta over this image. So this here you can see there is a clear coaptation gap between your tricuspid valve leaflet, and you can see there are severe TR. You can put color Doppler. Here also you can see there are coaptation gap. Similarly, their color Doppler have given you a TR. Now the is a post-operative post-CPB image. You can see over here, surgeon has repaired it, but still there are residual TR. And also you if you freeze the image, you can see there is a formation of PISA during your tricuspid valve inflow. That means it is a iatrogenic TS formation, tricuspid stenosis formation. So if you put colored continuous wave Doppler, you will examine for this patient, you have examined that this is a forward flow and your pressure gradient is 6. Mean pressure gradient is 6. In severe tricuspid stenosis, always remember there is no clear guideline. Particularly what is the echocardiographic criteria for severe tricuspid stenosis, but it is for the consensus it is a mean pressure gradient. If it is more than 5, it is considered as a severe TS. So in this patient, the patient has developed severe TS. So this is your coronary sinus view, deep esophageal, or deep esophageal tricuspid valve view. You can see over here. Can you see mitral valve leaflets? No. You can see over here the coaptation gap between tricuspid valve, and you can see your jet. You can see there are flail of your septal leaflet, and you can see the jet, the complex jet. It is originating and it is hitting the undersurface of your septal leaflet. Now you can see the mass over your tricuspid valve leaflets, septal leaflets. This is your anterior leaflet just near to the aortic valve. This is your septal leaflet. So this is the image at 25 degree. This is the same person image of 0 degree. This is the same person image of 47 degree. So you can see over here how the leaflets changes. And you can see over here, this is a endocarditis, tricuspid valve endocarditis, classical. But it is actually, the mass is actually attached with your septal leaflet. You can see over here. Same patient, color Doppler. It is another patient. You can see tricuspid valve. The mass is attached with your posterior leaflet, and you can see over here the color Doppler. There is an interesting patient. You can see over here there is no movement of your these two leaflet. This is the transgastric RV inflow view. There is no movement of this leaflet and there is no movement of this leaflet. Only septal leaflet is trying to close the orifice. There is a case of a carcinoid. So right now the TR has the grading of TR has added two more criteria, that is a massive and torrential. So up to 7 it was severe. So more than 7 that was considered as severe. If it is the vena contracta, if it becomes more than 13, that is 14 to 20, it is a massive TR. If it is more than equal to 21, it's a torrential TR. ERA also, if it is more than 60 to 79 is massive, more than equal to 80 is equal to torrential. Similarly, 3D vena contracta area. So what is this for? It has actually recently the transcatheter procedure has been done in this torrential and massive. So the severe also has some gradations. So accordingly, they have graded the, if the patient is having torrential TR and after the procedure the patient has developed severe TR, that means that is a considered as a improvement. So that is why there is a expanded grading of TR has been made. So this is how you can measure the tricuspid valve TR vena contracta. So vena contracta you can see over here 11.1 millimeter. This is your 3D vena contracta area. The area is 1.87 centimeter square. So this is your 3D vena contracta area. So if you put a Doppler over your hepatic vein, this is your normal waveform. This is your systole, this is your diastole, and this is your atrial. This is just like your pulmonary venous waveform. Whereas in case of severe TR, there is a systolic reversal that you can see over here is a systolic reversal. So how can you if ERO is calculated from your PISA, so 2 into pi into PISA into R square into VA by Vmax TR. That is similarly just like your MR or AR. So last few slides, I know I am making a late. Doppler calculations. So always remember, whenever there is no regurgitation or stenosis, you have to put laminar flow. If there is a laminar flow in a color Doppler, you'll have to put pulse wave Doppler. And if there is a turbulent flow, that means there is a stenosis or regurgitation, you have to put continuous wave Doppler. So if there is a cross-sectional area, and if if this is a waveform, if blood uh, starts to flow, whenever the valve is opening, the blood starts to flow like this, and it reaches a peak velocity, and then it slows down, and finally it reaches up. So this is the area under the curve. It is the distance that has this blood actually traversed through the time. So if we multiply this cross-sectional area with this distance, that means it will give you the volume of this cylinder. That means that will give you the VTI. So VTI is nothing but the volume of this cylinder. So that for the per unit time, how much blood is actually moving from this point to this point, that will give you the VTI. So here also stroke volume is equal to stroke distance into cross-sectional area. So what is the QP QS? What it is a it is an uh, it is how you will calculate in your RVOT. If you measure your RVOT diameter, and if you do a pulse wave Doppler of your RVOT, it will give you a QP. And if you do a LVOT diameter, that will give you a LVOT area, and LVOT VTI, it will give you a QS. So you can do a QP QS calculation by your Doppler examinations. Regurgitant volume, that I have already discussed. Regurgitant volume, it is a forward flow through regurgitation valve minus forward flow through the reference valve. That will give you the regurgitant volume. That means in case of your mitral valve, suppose you are examining a patient of MR. That means what is the regurgitant volume? It is the forward flow through the mitral valve minus forward flow to the aortic valve, because that is the blood that is coming back into the LA. It is already regurgitation volume, the forward flow through the aortic valve minus flow through the mitral valve. So it will be the regurgitation volume of aortic valve during your AR. So how the valve area is calculated? That continuity equation I've already discussed. That is A1 into V1 is equal to A2 into V2. So if you want to do A2, it will give you the A1 into V1 divided by V2. Just like you either you can take the V1, that is Vmax, or you can take the entire VTI. So whatever thing, it will be almost similar. So it is a major thing that I wanted to discuss. That is an intracardiac pressure gradient. The simplified Bernoulli equation is any pressure gradient between the two chambers is equal to 4V square. For what is the V2? V2 means it is the velocity of the blood in the next chamber. Whereas modified Bernoulli's equation, it is a 4V2 square minus 4V1 square. Is V2, that means suppose you want to know what is the pressure gradient between your LV and the aorta. That means what is the aortic pressure gradient, aortic valve pressure gradient in an aortic stenosis patient. So you have to uh, whenever you will put a Doppler, you will get a Vmax of your aortic valve, and you multiply into the square of that velocity. That will give you the pressure gradient. So what are the things that we can get? That is, if you RV systolic pressure or PASP is equal to 4 into VTR square plus right atrial pressure. PA mean pressure, that is 4 into V early PI square plus RAP. I am giving you the example. If you get a PR, and if you do a continuous wave Doppler, and if the highest velocity, that will give you the MPAP value. So if you get this is called a early PI velocity. This is your early PI velocity, that is pulmonary insufficiency velocity. So early pulmonary insufficiency velocity, this is your late pulmonary insufficiency velocity. So this velocity will correspond to your MPAP value. This velocity will correspond to your diastolic value. And PSP already we know that from your TR. So 4 into VTR square plus RA pressure. So that is how you can measure all the three pulmonary artery pressures. Along with that, if you want to know the LA pressure from your MR, you can simply SBP, systolic blood pressure, minus 4 into VMR square. And if you want to know the end-diastolic pressure, that is diastolic blood pressure, minus 4 into AI end square. What is AI end square? That means this is the velocity. This is the velocity of your AI end. That means it is the end velocity of your aortic regurgitation jet. So this is your 2.5 meter square. That is how you can calculate. Suppose this is a 2.5 meter square, and that is how you can calculate your LVEDP, because your BP is 142. That means your systolic blood pressure is sorry, diastolic blood pressure is 52. So 52 minus 2.4 into uh, 2.5 square. That will give you the LVEDP value 27. What is the left atrial pressure? Left atrial pressure, just like your MR, is a Vmax of MR. If you know your systolic blood pressure 100, MR peak velocity is 4.5, and for so 100 minus 4 into 4.5 whole square, that will give you the 19 millimeter of mercury left atrial pressure. So this is how you can see over here a little jet of your PR. If you put Doppler over here, that also you can put Doppler here in your upper esophageal aortic arch short axis view. There you can put Doppler over your pulmonary valve for any pulmonary regurgitation velocity. In this view also, deep esophageal, sorry, transgastric, deep transgastric RV inflow outflow view, both 0 degree and 120 degree. In these views also, you can put Doppler over your tricuspid valve, as well as you can put Doppler over your RVOT and pulmonary valve. So that was all for today.
Thank you, Abhinandan.
Thank you.
Thank you very much for detailed discussion. Let's see if there is any question. And Mole has written amazing class, sir. Please ask any question, audience. If there is any confusion, you can clarify.
Acha, where to put cursor for aortic diastolic flow reversal? You will go to that, that is your descending thoracic aorta long axis view, and you can put your pulse rate Doppler cursor either to any side of your aortic valve. Sorry, in your aorta. Either you can put towards left side, or you put on towards right side. It will just give you a mirror image. By both the side, you can put the Doppler. Always remember, you always attach your ECG, and it will give you the exact phase of the cardiac cycle that you are dealing with. That will also tell you which one is the diastole and which one is the systole.
Okay.
Acha, regarding RVOT VTI, where to keep Doppler and views. In case of your RVOT VTI, you can put Doppler in your deep transgastric RV inflow outflow view, and also you can put Doppler if you get a good view of upper esophageal aortic arch short axis view, where you can put a Doppler just below the level of your pulmonary valve.
So, okay. So I think you have covered it's everything in quite detail. So, and it's quite big, big thing and very useful for everybody. Actually, it's very useful. So
Thank you.
Thank you, Abhinandan, and
Thank
all the
you. Thank you. Thank
participants. And we will join again next Saturday
you.
with in continuation with this eco series.
Okay.
Thank you, everyone. Thank you,
Thank you.
Abhinandan.
Thank you. Thank you, sir.
Okay, bye bye.